Hello, class. How's it going? Ready for Chapter 1, Movement Anatomy, Kinesiology 360? Cal State Fullerton. Here we go. All right, so Chapter 1 is pretty long in a sense that it builds a foundation of where we're going to get started from. So I want you to really take the time and look over the material. Some of it will be review, some of it will be something new. So we'll take a look. Let's see. All right. So before we get started, we got to say, hey, why are you in school? Now, an idle brain is the devil's workshop. Now, you can interpret this many ways, but when you sit at home and do nothing, basically your mind goes astray. You've had people in your family that pretty much they stay home and they don't do anything, and what do? They end up gossiping about other people, right? So we have to find a way to keep your brain engaged, and hopefully throughout the semester I'm going to give you some good analogies, give you some situations where you have to think a little bit and you'll be like, okay, my brain's working again, instead of just sitting at home surfing the internet, watching TikTok or whatever you do. Not to say that TikTok is not entertaining, but the brain doesn't really do much, and then the devil's workshop can begin. So let's get started here. My name is Dr. Patel. Physical therapist for 21 years, 19 years as a certified strength and conditioning specialist, 16 years as a professor at Santa Ana College, Community Coastline, Cal State Fullerton, and Stanbridge, which is a physical therapy assistant program. Once in a while, I've limited my patient contact, so I see patients Monday, Wednesday, Friday, but I've been doing more teaching during this COVID-19, so more teaching, less patient contact. Outpatient orthopedic clinic owner. I travel to India for guest lectures. Now I've actually given a few lectures online via YouTube, so if you type up my name there in YouTube, you might see a few lectures here and there. Might see I have been on the student advisory committee at Chapman, and I love to travel. Travel to India, Dubai, Costa Rica, Alaska, Hawaii, Canada, Thailand, and Singapore. Unfortunately, with COVID-19, all my traveling has been put on hold, but hopefully this will resume relatively quickly. All right, here's a little clip of me on the Clipper. Clipper. Oh my God, had a Laker game here. Here I am here. Look at this. This guy was throwing. Here's Kobe, Meta. Got my 15 seconds of fame on ESPN. All right. So there we go. This was when they had Steve Nash, Dwight Howard. This was in Phoenix. These guys were throwing beers and popcorn at me, but that's right. All right, so let's get started here. Kinesiology. Study of the principle of anatomy, physiology, and mechanics in relation to human movement. So that's the definition of kinesiology. Make sure that you know that. You might see that again on a quiz. And what I'll try to do throughout the semester is, if I see something that's important, we'll definitely try to point that out. But any kind of definition, especially the definition of kinesiology, you should know. Structural kinesiology, which is the study of muscles, bones, and joints as they are involved in the science of movement. Of course, bones vary in size and shape, and we'll talk about that throughout the semester. They affect the amount of type of movement that occurs between them and the joints. So depending on the relative size of the bones, will definitely vary in size and shape and affect the type of movement. Okay, so yeah, look at this guy. Types of joints vary in both structure and function. Muscles vary in size, obviously, shape and structure from one part of body to another. There's more than 600 muscles found in the human body. Now, do you have to know all of them? No. But look at this. This is ridiculous here. But you can point out the muscles, nice deltoid, pectoralis major, rectus abdominis, external obliques, vastus lateralis, rectus femoris, vastus medialis, adductor magnus, right? So you can really point these out, and you should be able to point these out. You've taken anatomy before, so the goal of this class will be to see the relationship between each one, see who the antagonists are, the agonists, concentric, eccentric movements. Okay. So who needs kinesiology? Well, anatomists, coaches, strength and conditioning specialists, personal trainers, nurses, physical educators, therapists, occupational therapists, physicians, athletic trainers, massage therapists, and anyone really related into the health related field. So if you're going to go into any health related field, you should probably know some kinesiology and definitely know your anatomy. Why is kinesiology important? Well, provides an adequate knowledge and understanding of all large muscle groups to each other, how to strengthen, improve, and maintain optimal function of the human body. In certain instances, professionals in medical and sports fields should know more detailed programs that are needed to address certain muscles, and basically that forms the basis of exercise programs followed to strengthen and maintain all the muscles. So if you don't really have a good concept of kinesiology or a good concept of which muscles are working at what time, you're just really wasting your client's time and maybe your athlete's time and not getting the results that we need. So throughout the semester, hopefully you get a deeper understanding of what we're trying to accomplish, and by understanding kinesiology, muscles, and which joints are involved. Before we start, whenever we deal with something, we always refer to a reference position, and it's called the anatomical position. It helps us better understand the musculoskeletal system and planes of motion, joint classification, and joint movement terminology. So when somebody asks you a question, you always want to know that it's referring to them in the anatomical position. Now the fundamental position is different, so make sure you know the difference between the two, because that would be a good quiz question. But the anatomical position is most widely used and accurate for all aspects of the body. You're standing upright, facing straight ahead, feet parallel and close, and here's the kicker, the palms are facing forward. In the fundamental position, it's basically the same thing, but guess what? The palms are facing the body. So that's the key difference between the anatomical position and the fundamental position, so you want to know that. Also, as far as terminology is concerned, this is right, this is left, but look, you're looking at them, but you're still, a right is still a right. Okay, so you don't want to say, oh, it's my right, your left, my medial, your lateral. No, you always refer to them in the anatomical position. So the right is always the right, the left is always the left. It's not that you reference it of how you're looking at that patient. Because think about that. The patient, the client, they could be lying supine, they could be lying prone, they could be lying upside down, right? But it's still, the right is still the right. So you always refer to them in the anatomical position. Distal would be furthest away from the trunk or the body. Okay. Proximal would be closest to the trunk. Okay. Medial is towards midline. Lateral is away from midline. Okay. And distal again. So a good quiz question would be, or a good example would be, the ankle is distal from the knee, right? So yes, the ankle is distal from the knee, but the hip is proximal to the knee. That's right. The hip is proximal, meaning it's closer to the trunk than the knee, so it's proximal. Okay, so make sure you learn that terminology. The forearm is lateral to the trunk. That's right, it's lateral to that. But the spinal cord, or the spine, is medial to the forearm or arm, right? Again, this is arm, this is forearm, this is your thigh, and this is your leg. So this is not your leg here, this is thigh, this is leg, this is your arm, and this is your forearm. Okay. To further assist in understanding the location of one body part in relationship to the other, well, you have the mid-axillary line, the line running vertically down the surface of the body, passing through the apex of the axilla, the armpit. You have the mid-sternal line, the line running vertically down the surface of the body, passing through the middle of the sternum. Okay, so here's the mid-sternal line, here's the mid-clavicular line, and here's the right anterior axillary line. So you want to know these three different lines here. You have a posterior axillary line that is parallel to the mid-axillary line and passes through the posterior axillary skin fold. You have the mid-clavicular line, the line running vertically down the surface of the body, passing through the midpoint of the clavicle. And then you have the mid-inguinal point, which is the point between the anterior superior iliac spine and the pubic symphysis. Now, as you can see, we're diving right into anatomy, so you should already know where anterior superior iliac spine is, where the pubic symphysis is. I'm assuming that you took anatomy class and you have this. So if you didn't do so hot in anatomy, then this movement anatomy class is going to be a little tough, because now you're going to have to review basic anatomy and then learn how the movement relates on top of that. So that's why anatomy is the foundation of your career, and you really want to spend the time knowing your anatomy. So if this is your first time really learning it, I want you to take the time and really try to emphasize this as much as possible. Okay. Now, the scapular line running vertically down the posterior surface of the body, passing through the inferior angle of the scapula. And then you have the vertebral line running vertically down through the spinous process of the spine here. All right, the anatomical direction terminology. This is anterior, this is posterior, proximal, and distal. Anterior means in front or in the front part. Anterior inferior means in front and below. Okay. Anterior superior means in front and above. Anterolateral means in front and to the outside. Anteromedial means in front and toward the inside. Okay. Anterior posterior relating to both the front and the rear. So if you look at this is the superior view of the right knee, and you can find that the medial meniscus is in the anteromedial section. Okay. The lateral meniscus is in the anterolateral section. All right. Now the posterior, behind in the back or in the rear, posterior inferior, behind or in the back and below, and posterior lateral, behind and to one side, specifically to the side. Now, why these directional anatomical are important, especially with knee injuries, is you want to be as specific as possible. So let's say I had a scenario where I mentioned that a patient or a client was hit or had a contusion in the anteromedial portion of their knee. And then you could say, okay, well, maybe their meniscus, their medial meniscus might have been affected, right? Or if I say, oh, they had a fracture in the posterior lateral section, then you're thinking, okay, if they had a fracture in the posterior lateral section, well, that could be the lateral tibial plateau, and that could be a tibial plateau fracture, right? So tibial plateau fractures are very common in snowboarding, but actually Kobe Bryant actually had a tibial plateau fracture as well. They are rare, but with a lot of stress and a lot of jumping, and that can occur. Okay. Posterior medial, behind and inner side. Posterior superior, behind or in the back and above. So make sure you kind of know these directional terms, because those are very easy quiz questions that we can ask. Contralateral, meaning pertaining or relating to the opposite side. Ipsilateral means to the same side. And bilateral, meaning relating to the left and right side. So if I say I have an injury to the right side, then the contralateral side would be the left. Correct? Okay, so the ipsilateral would be right knee, right shoulder. Bilateral would be right and left shoulders. But make sure you contralateral, so if I have an injury to the right shoulder, then my contralateral side would be the left shoulder. Inferior or infra, below in relation to another structure, caudal. So the knee is inferior to the hip, right, below. Superior, above in relation to higher or cephalic. So the elbow is superior to the wrist, or the shoulder is superior to the elbow. Inferolateral, below and to the outside. Inferomedial, below and toward the midline or inside. Superolateral, above and to the outside. Superomedial, above and toward the midline or inside. So knowing these relationships, superolateral would be the lateral epicondyle. Superomedial, medial epicondyle. Okay, so knowing the relationships between the two would be beneficial. Caudal means below in relation to another inferior, and cephalic is higher or superior. So cephalic is just another word for superior, and caudal is just another word for inferior. Caudocephalid, directionally from tail to head in the long axis, so you're moving from the tail to the head. Cephalocaudal, directionally from the head to the tail to the long axis. So the person can have pain running cephalocaudal, so meaning from the head to the tail, or they could have pain from the caudocephalid, which is from the tail to the head. Deep, beneath or below the surface, used to describe relative depth or location of muscles. So the biceps is deep to the skin, but the coracobrachialis is deep to the biceps. Superficial would be the skin is superficial to the biceps, but the biceps brachii is superficial to the coracobrachialis. Or another example would be pectoralis major is superficial to the pectoralis minor, or the pectoralis minor is deep to the pectoralis major. You're thinking, oh my God, Patel, you got me all over the place. Well, it is a play on words, but the more you understand anatomy, the easier it is. But you definitely want to know this terminology. All right, distal, situated from the center or midline of the body or away from the point. Proximal, nearest the trunk or point of origin. I gave you some examples earlier, but again, to reiterate, let's say the wrist is distal to the elbow, right? Situated away from the center or away from the point of origin. The shoulder is proximal to the elbow, right? Because it's proximal, it's closer to the midline or the trunk than the elbow. So make sure you know those. Those are great true or false questions. Lateral, on or to the side. Medial, relating to the middle or center. Median, relating to located in or extending toward the middle. Okay. Dexter. You ever watch that show on, was it HBO, Dexter? But the real medical term for Dexter, or what it really means, is situated to the right or on the right side of something. So Dexter means right. Sinister, you know what sinister means, but really sinister means situated to the left. You might think sinister as an evil, but the anatomical directional terminology of that is to the left. So if you're lefties, you could be sinister. Some of you are like, oh yeah, that holds true. Prone, face downward position of the body, lying on the stomach. Okay, so prone. And supine is lying on the back, face upward position of the body. Now, a lot of times when you go to the medical clinic or you go, the nurse tells you to lay down. That's not really proper English. Really, it's lie down. Just remember that chickens lay and people lie. So when you ask a patient, a client, or an athlete, don't tell them to lay down, tell them to lie down. Dorsal, relating to the back, being or located near or on toward the back, posterior part, relating to the top of the foot. So the top of the foot is the dorsal pedis. Okay, ventral, relating to the belly or abdomen, on or toward the front, anterior part. So make sure you know the difference between dorsal and ventral. Again, this is pretty much review of anatomy, review of medical terminology, but today's the first day. let's just do a nice review, but there's a lot of information. So if you didn't know this from the beginning, you have a lot of catching up to do, because I'm going to use this terminology throughout the entire semester. Palmar, relating to the palm or volar aspect. Volar, relating to the palm of the hand or sole of the foot. Plantar, you've heard of plantar fasciitis, so plantar, relating to the sole or undersurface of the foot. Fibular, relating to the fibular lateral side of the knee, leg, ankle, or foot. Tibial, relating to the tibial medial side of the knee, leg, ankle, or foot. Radial, relating to the radial lateral side of the forearm. And ulnar, relating to the ulnar side. Remember, you ever watch that movie Rad? It's old school 90s, where it's just about BMX biking. But the way I remember Rad is radial, thumbs up. You do a thumbs up, that means the radius is on your thumb side. So rad, dude. Hey, whatever it takes for you to learn the material, right? Ulnar, relating to the ulnar side. Scapular plane. Now, usually when you do exercise, you want to do shoulder exercises in the scapular plane. And it's aligned with normal resting position of the scapula as it lies on the posterior rib cage. Movements in the scapular plane are aligned with the scapula, which is at an angle of 30 to 45 degrees from the frontal plane. So if you look at the frontal plane from the side, you come 30 to 45 degrees. And really, you should be doing shoulder exercises in this. If you do it out to the side, or if you do it in the front, you run the risk of subacromial impingement of the biceps tendon. So you really want to work in this scapular plane right here. So whenever somebody comes in for shoulder pain or shoulder rehab, we try to find the scapular plane and try to do exercises in the scapular plane. All right. Now, anteversion, which is abnormal or excessive rotation forward of a structure, such as femoral anteversion, give you more hip flexion. Okay, toes forward. Retroversion, abnormal excessive rotation backward, such as femoral, will need to toe out with squats. Okay, so you see when you go to the clinic or you go to the gym, and sometimes the trainers will say, hey, keep your foot forward and then try to do a squat. The problem with keeping your foot forward is if they have an anteversion or retroversion, what's going to happen is they're going to pinch the inside of their hips. They'll say, oh, that hurts. Or what you'll see is what we call the butt wink. And what happens is there's no more room or real estate for the patient to go down. So instead of flexing at the hip, they'll start flexing at their spine, and you'll see their butt kind of go into this flexion, and they'll wink. So you can, when we do the overhead squat assessment, we'll look at that and we'll see how many people run out of real estate quickly, and you'll see that the pelvic will tilt forward. You're thinking, oh my gosh, is that normal? Well, there are things that we can do to correct it. But if you constantly, let's say you have 100, 200 pounds and you're doing an overhead squat with weight, and then your spine goes into flexion, well, you run the risk of herniating your disc right there, or putting a lot of stress on the low back. So there are some things that we'll definitely have to look at to make sure that you're doing them correctly. Okay, so make sure you know the difference between anteversion. That will give you more hip flexion. Your toes are forward. So anybody that has that, then you'll be able to go down into a full squat. So you'll see patients that have anteverted hips, they'll be able to squat down just like the Asian squat. So if you have retroversion, then you're going to have to toe out a little bit more to be able to go down, because you're going to have to be able to go down. So again, this goes back to knowing your anatomy, knowing the position of the hips, instead of just forcing, oh, come on, you can do it, and causing your client or athlete pain. Now you can understand, okay, what is anteversion? What is retroversion? Do they have a bias towards flexion in their spine because they ran out of real estate here? And do they have this butt wink? How do we correct it? So there's lots of things that we want to look at, and the more you know anatomy, the more you understand the movement and the relationship of each, you'll be that much better. And hopefully throughout the semester I'll be able to give you my tips and all the things that I use in the clinic, which I think will definitely help you. So if you look at femoral versions, okay, so here it is here, 15 to 20 degrees. Here's a version here that could be 20 degrees, and then here's 5 degrees here. So these are all different variations of femoral versions here. Okay, and all these can affect, can you squat, can you lunge? And we'll show you as we do the hip, I'll actually show you how to measure this later on. Okay, now you've heard of kyphosis, lordosis, and scoliosis. Well, kyphosis is probably what you're going to develop because you've been sitting at home on the computer all day and watching your Instagram or whatever you guys are on right now. Okay. Your lordosis is increased curving of the spine inward or forward of the lateral. So here, think J-Lo, right? Okay, so that's lordosis. Kyphosis, think anybody with bad posture. And then you have scoliosis, which is the lateral curving of the spine. Okay, and scoliosis affects teenage women or girls more than men. So you remember in the 8th grade, I don't know if they still do this, but your gym teacher had you bend forward and then they checked if your spine was rotated, and they were checking for scoliosis. Now, here's another variation of the knees. You have knock knees versus bow-legged, and then you have recurvatum, which is bending backward as a knee hyperextension. Some of you like to hang out like that. When you stand, you'll hyperextend that knee. The valgus is outward angulation of the distal segment of the bone, such as knock knees. So that's valgus. Varus is inward angulation of the distal segment of the bone, as in bow legs. So this is varus. Okay, so make sure you know the definition of valgus, and make sure you know the definition of varus. What's recurvatum? Okay, so all these are just simple reviews, simple medical terminology, but really something that you should know for day one. So the objectives of day one were to learn the anatomical position and basically directional terminology and some variation terminology. So hopefully you were able to do that. What you can do is make flashcards, look at something visual, read the book. Again, this is going to be all on you, where it's going to creep up on you if you wait till the last minute. You're thinking, oh, we're just having Zoom meetings, we don't need to. But I tell you, you'll fall behind real quickly. You don't have me in front of class telling you, did you do this, did you do this? I mean, I will still email you and say, hey, we should have done this, but you have to be disciplined and you have to take control. Otherwise, you're going to end up with a bad grade, and there's nothing we can do later on. So start off strong and do the best you can. I don't mind giving everybody a good grade if you deserve it, but you really have to work hard at it. Okay? All right. End of day one. You made it. Nice. I'll see you Wednesday at the same time. Don't be late.